Good morning. Welcome to CAC2's November webinar, where we're going to explore the progress and challenges associated with developing new strategies for refractory and relapsed neuroblastoma patients. Gavin Lundberg, a CAC2 member and president of the Evan Foundation, will introduce an exciting panel of speakers. They will share about this multi-institutional network, their collaborations with the Children's Oncology Group, as well as other partners, their current clinical trials, and their plans for future studies in neuroblastoma. I'd like to thank you all for being here today, particularly as we become weary of screen time. Before we get started, I'd like to remind you of CAC2 news and opportunities that we have been working on. You can view last month's webinar on the Pediatric Data Commons on the CAC2 website, which is cac2.org/news. And at that same spot, you can keep up with research, breaking news, and online opportunities with our weekly Childhood Cancer Community News Digest. You can learn about interesting things like that CAC2 members responded to an international survey conducted by the ICRP about the effect of COVID-19 on research funding. The impact was clear that 100% have felt the revenue pinch, that 93% anticipate decreased funding being available for childhood cancer research in 2020, and an average of 45% decline. Many organizations were shifting funding to help offset the financial impact of COVID-19 on families with emergency funding. Also, on Monday, November 21st, which is the longest day of the year, CAC2 will lead a social media opportunity calling attention to the long night children, parents, and all in our community experience. We would like to welcome new members to the presentation and remind those who need to renew that they can do so at members.cac2.org/renew. Additionally, we have a few housekeeping notes. You are all on mute. Our panel has agreed to take questions, but we would like to defer these to the end of their presentations. As always, you can post questions by typing it on your webinar dashboard. We always put children and their families first in everything that we do. And we start all of our meetings with our values. We support members in the childhood cancer community while being mindful not to compete with members or to duplicate projects or programs or services that they provide. We try to be accountable and take ownership of our commitments within the collaborative. We strive to be cost effective and mindful of our resources. We're inclusive and collaborative and assume a positive intent. And we stay action focused and flexible. I'd like to thank my partner, Robin French from the Morgan Adams Foundation for her help with this webinar series and all of her support. And it has been an absolute pleasure to work with. And now it's my pleasure to introduce Gavin Lundberg from the Evan Foundation, who is also Evan's dad. He's the one that suggested this webinar, and he will introduce our panel of speakers. Thank you.
Well, Anne, thank you very much, and hello, everyone. It's great to have you with us. Let me start with a big thank you to CAC2 for hosting the webinar today. Particular round of applause for our president, Vicki Buhner, and the wonderful webinar team of Ann Raymer and Robin French for their help in organizing this event. And just also wanted to take a minute to recognize it as Veterans Day here in the US and thank all the veterans and their families for their service. I know that we have some veterans on the line with us today, so thank you. As the moderator of today's program, I'm joining you from my home in Maryland, just outside of Washington, DC. And as Anne mentioned, I'm an advocate for better treatments and hopefully one day a cure for neuroblastoma. And the reason I do that is because of this guy you see here on the screen. This is my son, Evan. And Evan was diagnosed with stage 4 MYC amplified neuroblastoma in 2006 at the age of 3. And after a 4-year battle that defined courage, treatment failed Evan in October of 2010, and we lost him at the age of 7. And he was our only child. So his mom, Wendy, and I have dedicated the rest of our lives to helping improve outcomes for children like Evan who are battling this terrible disease. To help us do that, in 2011, we established the Evan Foundation. And the foundation funds promising neuroblastoma research, including a number of NANT projects over the years. And also, as a quick aside, we also sponsor what we call Treats and Treasures carts at children's hospitals across the country. These are carts that bring a little joy to children who are undergoing cancer treatment and long and difficult stays in the hospital. So if you have a hospital in your area who you think might be interested in benefiting from a Treats and Treasures card, I hope you reach out to me. And let me just also mention that the Evan Foundation has been a proud member organization of CAC2 really since the very first days of the coalition. And boy, for almost a decade now, I've had the honor of serving on the NANT Parent Advisory Committee. And one of my colleagues on the committee is our dear friend and fellow CAC2 member, Donna Ludwinski, who I know is with us today. And Donna and I are very excited for this opportunity for the audience to hear about the great work that the NANT Consortium has done and is doing and will do to advance neuroblastoma research as we celebrate NANT's 20th anniversary. So to do that, we have 3 world-class speakers, all of whom are senior leaders in neuroblastoma research and patient care. They're all passionate about what they do for children and families, and they are principals, senior leaders in NANT, going back many years, in some cases all the way to the beginning. So with that, let me introduce them, and I want to start with Dr. Kate Mathey. Dr. Mathey is a professor of pediatric oncology at the University of California, San Francisco School of Medicine, and she formed and led the NANT Consortium for 20 years. Kate is internationally known for her leadership in neuroblastoma in the COG, PSYOPs, ANR, which is Advances in Neuroblastoma Research Association, and the Global Neuroblastoma Network. Dr. Mathey will be presenting on 20 years of progress in the NANT. Next up is Dr. Judy Villablanca. She is a professor of clinical pediatrics at Children's Hospital Los Angeles and the University of Southern California. Judy was the founding co-leader of NANT and established and led the NANT Operations Center in Los Angeles until 2012. She's internationally recognized as a clinical investigator in neuroblastoma, including trials of myeloablative therapy and retinoids. And Judy will lead us in a discussion on current NANT clinical trials. And then our third speaker is our friend, Dr. Steve Du Bois. He is a pediatric oncologist at the Dana-Farber Boston Children's Cancer and Blood Disorders Center. Steve leads a clinical research program focused on targeted therapies for high-risk neuroblastoma and is the chair of the current Children's Oncology Group trial for children with newly diagnosed high-risk neuroblastoma. He is a member of the executive committee for both NANT and the COG Neuroblastoma Committee. And Dr. Du Bois will present on the partnership between these two consortiums, specifically the approach to translating findings from the NANT to the COG. So without further ado, let me now turn the program over to Dr. Mathey. Thank you.
Thank you very much, Gavin, and thank you, CAC2, and all of you for listening. It's indeed a privilege to be invited. Okay, sorry. I will, something is weird there. There, I'm sorry. I have a lot of things showing on my screen for some reason. So the NANT Consortium was started, as you heard, 20 years ago by myself and Judy Villablanca, my co-leader and head of the Medical Operations Office. But we were very pleased to turn the baton over to Julie Park, who now leads the NANT, and Araz Marashelian, who leads the Medical Operations Office. There we go. Okay. No. The NANT was formed as part of a program project grant sponsored by the National Cancer Institute, which is a collaboration of multiple scientists doing preclinical research and basic research in neuroblastoma from UCSF, Children's Hospital of Philadelphia, the Dana-Farber Institute, Children's Hospital Los Angeles, and we also have participation from Stanford and University of Ohio, all of them developing therapies which feed into the NANT consortium with new targeted and immunotherapy clinical trials. So this is just a screenshot of our website. We have now, since 2000, designed, initiated, and completed 25 early phase trials. And we have treated now more than 760 patients with resistant neuroblastoma. And this is all a team effort and collaboration with the Children's Oncology Group to provide data for future studies to change therapy for upfront patients. This shows you the distribution of our NANT sites. We have 14 full NANT sites shown in red, and we also have 6 guest members, including international members from Australia, France, the United Kingdom, and Canada, and as I mentioned, also Columbus, Ohio, and Stanford. What I consider the major accomplishments of NANT in our first 20 years are, number one, major advances in MIBG therapy, in targeted inhibitors targeting various mutations and abnormalities in neuroblastoma, new combination therapy with anti-GD2 therapy, now cellular therapy combined with targeted agents, as well as quantitative and molecular new response criteria, and in general translation from bench to bedside and back. First, I will talk about a few examples of these things. First, for MIBG therapy, we looked at single agent MIBG therapy after it was shown that MIBG was active in other single institution and pilot studies. We showed that we could give MIBG twice with a 2-week interval, a rapid infusion. We tested a new form of MIBG with a higher specific activity, which could be infused more quickly and is potentially more active. We had 2 studies, phase 1 and 2, combining MIBG with myeloablative chemotherapy and transplant, which have now led to 2 COG studies. And we have more recently combined MIBG with radiosensitizers, both with irinotecan vincristine and with an HDAC inhibitor, HDAC-E, which I will tell you more about. So HDAC inhibitors slow the growth of neuroblastoma by changing levels of gene expression. Vorinostat, which is one HDAC inhibitor which is approved, has been shown by groups at UCSF to both increase expression of the norepinephrine transporter, which is how MIBG gets into the cells. And then, as you can see in this graph at the right, it increases uptake of MIBG with increasing concentrations of vorinostat. And this, the 2 columns represent 2 different neuroblastoma cell lines. We also showed that vorinostat combined with radiation therapy decreases neuroblastoma growth in a metastatic xenograft. We then performed a dose escalation study up to 18 millicuries per kilo in 27 patients, led by Steve Du Bois, and showed a good response by MIBG response in these patients. So the vorinostat there you can see in the schema was given for 14 days and the MIBG on the 3rd day. We then performed a randomized phase 2 trial, again led by Steve Du Bois, where we compared MIBG alone to MIBG with vincristine irinotecan, the radiosensitizer, and to MIBG vorinostat. And we looked at response and toxicity to find out if we were really improving MIBG. And you can see when you look at response to the first course of these 3 regimens shown in the left-hand column, that the response was more than double with the MIBG vorinostat combination compared to the MIBG irino or the MIBG alone. And this represented a total of 105 patients. And although many of these patients had had prior irinotecan or prior vorinostat or prior MIBG, these were equally distributed across the arms. So we do not think that this influenced the outcome. Next, let's move on to an example of our immunotherapy trial. This was led by Araz Marashelian, looking at lenalidomide along with isotretinoin or Accutane with dinutuximab, the anti-GD2 antibody. It had been previously shown that lenalidomide increases numbers and activities of NK cells and also decreases a number of cells that enhance tumor growth, such as immune-suppressing tumor-associated macrophages and Tregs. Lenalidomide is FDA approved for several adult indications, and a safe pediatric dosing was already identified. Dr. Seeger's lab in Los Angeles showed impressive synergy data with NK cells in a mouse model and with monoclonal antibodies. And we already know that isotretinoin and dinutuximab both have activity in neuroblastoma and are safe. So in this protocol, we gave lenalidomide for 3 weeks, dinutuximab the second week after the lenalidomide had presumably activated NK cells, and then the isotretinoin for 2 weeks. And we showed, indeed, that this was well tolerated at the highest dose level of this combination. We saw a response signal with 19% responses and another 19% with minor responses, which means that patients responded either by MIBG or bone marrow or in their solid tumor, but had stable disease in the other measurements. And this has now led, we found that there was immunomodulation looking at NK cells and cytokines in these patients. And this has led to an ongoing trial where we actually are infusing natural killer cells with which Dr. Villablanca will tell you about. So now we will move on to an example of a targeted inhibitor combined with chemotherapy. And this is a trial of MLN8237, which is also known as alisertib, and it is an aurora kinase inhibitor. Aurora kinase is an enzyme kinase overexpressed in neuroblastoma, and its expression correlates with inferior outcome. And it works by binding to and stabilizing MYC protein, so making the cells more aggressive in the MYC pathway. Alisertib is an oral aurora kinase inhibitor, which has been shown to have activity in neuroblastoma and has already been tested as a single agent in patients. We also showed additive effects of this agent with irinotecan and temodar in mouse models. So we embarked on this phase 1 study where we gave the MLN8237 or alisertib for a week, along with the irinotecan and temodar for 5 days. And in a phase 1 and then a phase 2 study led by Dr. Du Bois, we found this regimen was safe and effective. We found a very exciting 2-year progression-free survival in the phase 1, a little lower in the phase 2. And we found that patients had a response rate of 21% in the phase 2 study. And we also tested an oral solution, so we could use this type of agent in infants. So that also has led to a new NANT study with an aurora kinase inhibitor, which Dr. Villablanca will tell you more about. Then I know that many of you are interested in DFMO, which has been tested by other consortia for patients in second remission. However, we decided to see if we could really push the concentration of DFMO and combine it with another drug, celecoxib, to help it and combine them with chemotherapy. And in this phase 1 trial, we used the DFMO, which is known to target NMYC pathways by regulating polyamines. The DFMO is an inhibitor of ornithine decarboxylase, which is a MYC-N target and is activated by MYC-N. The DFMO is an irreversible inhibitor of this pathway. And in addition, the celecoxib induces polyamine export. So in 2 ways, you're blocking polyamine accumulation in the cells, which then blocks the MYC-N pathway. And Dr. Hogarty in Philadelphia has extensive preclinical data supporting this combination. So our study looked like this. Patients got DFMO and celecoxib for the first week and then continued for 3 weeks, and they got the chemotherapy combination the second week. We established a recommended phase 2 dose that you see here, much higher than in some of the other trials that are ongoing. We showed a median time to progression of 19 months. We showed this was bioactive, and this has led again to a COG trial, which is randomized so that we can really see if this is better than chemotherapy and dinutuximab alone. Finally, I'll just share with you a few interesting studies we have done with our biorepository in NANT. From the beginning, we started collecting tumor when we could from these relapsed patients, and from all of them, blood, plasma, and bone marrow to do special studies on. And in addition, we've made a biorepository of images from all these patients, which we can correlate with their outcome and their biology. So we have CT and MRI images and MIBG scans. 2 interesting studies have already come out of this, which I'll share with you. One, a test of sensitive minimal residual tumor detection in bone marrow and blood by RT-PCR. And one looking at our more quantifiable response criteria we have developed in NANT to see if they actually correlate with outcome in relapsed patients. A new trial, again, which Dr. Villablanca will discuss, is ongoing in precision medicine, where we are doing genetic analysis from bone marrow and on blood of relapsed patients. And of course, with this biorepository, we are also doing pharmacokinetics and pharmacodynamics in all our studies. So this NB5 assay, developed in Dr. Seeger's lab and in a study led by Dr. Marshalian, tests 5 different genes in neuroblastoma that you can detect in bone marrow and blood patients with tumor. And this, we have shown that this sensitive RT-PCR assay will predict progression-free survival in all patients. In patients where it is negative, they have a much better survival than in patients where you can detect tumor. And what's very interesting, you see at the bottom of this, is that even in patients where the bone marrow looks negative for tumor under the microscope, which means that there is certainly less than 1% of bone marrow cells occupied by tumor, we can detect tumor by the RT-PCR assay. And in bone marrow, if it is undetectable, shown in the blue line, the outcome, the progression-free survival, was 100% at 2 years. In blood, which is a little less sensitive than bone marrow, we still showed that when tumor was undetectable by this assay, the patients did much better. And this assay is now being investigated in some of the COG studies with immunotherapy. Another outcome using our biobank, our repository of images, was we studied, we wanted to look at our quantitative NANT response criteria. So we studied 213 patients with relapse who had been on our phase 1 and 2 studies. And we looked at their tumor's size by RECIST criteria. We looked at their MIBG Curie score, and we looked at their bone marrow with central review of the slides by Dr. Shimada. And our results showed that using these quantitative criteria, patients who were in complete or even partial response had a higher progression-free survival, though it was not significant, but had a significantly higher overall survival. And you can see in this survival curve on the right in green, the much better progression-free survival for patients who are in complete response, and somewhat better for patients who are in partial or mixed response or stable disease than those shown in red who had progressive disease. We also noted that patients with refractory disease had a better progression-free survival and overall survival. MYC and amplified patients, although they had a lower progression-free survival, did not have a lower overall survival. And those with a higher Curie score in general, that predicted a lower progression-free survival and overall survival. So I think that we find that over the 20 years, we have had an impact of NANT. We've shown you can translate from the lab to the clinic using this group of investigators working together in the program Project GRAD. We've shown that several NANT trials are leading or have led to COG phase 3 trials. We have developed new approaches to combination immunotherapy and cellular therapy. We have advanced and optimized MIBG in combination, leading to national trials. And our response criteria have informed new international response criteria, both upfront and for patients after relapse. And none of this would have been possible without you as parents willing to advance the cure of neuroblastoma by putting your children onto these trials that provide new hope. So I want to thank all of you. And I will now turn this over to Judy Villablanca, who will tell you about our current trials.
Thank you, Kate. I'm going to apologize up front that I have camera access issues, so I will only be able to speak. You'll not be able to see me. And I'd like to again thank CAC2 for this invitation to speak, and to Don and Gavin for facilitating that. Next slide. I'm going to tell you today about the trials we currently have running for in NANT, which are targeted at relapsed refractory high-risk neuroblastoma. We do not do trials in newly diagnosed. Our average patient trial enrollment per year for the 2015 to 19 time period is 42 patients a year on therapeutic trials and 49 patients a year on the biology trial, which is the one Dr. Mathey described, where we bank samples and also their radiographic images. And we also do the NB5 assay to look at minimal tumor detection. Our current protocols really fall under two therapeutic approaches. The first one is optimizing immunotherapy, since we know that dinutuximab-based immunotherapy significantly improved survival in a randomized frontline study, and yet patients still do relapse following this. So we still need to understand how to do better. And secondly, protocols targeting molecular pathways, and I'll go through each of these in subsequent slides. First of all, we have a trial that utilizes natural killer cells. So natural killer cells are a subset of lymphocytes. They are able to kill tumor cells without the addition of antibody, but this cartoon here shows you how they function with an antibody. The molecules, antibody molecules shown in the center between the cancer cell and the natural killer cell. And the antibody helps to target the NK cell into the cancer cell, where it then releases perforin and granzyme to kill the cancer cell. One of the obstructions in doing natural killer cell trials is obtaining enough cells to infuse into the patient from a peripheral blood sample. And Dr. Dean Lee at Nationwide in Ohio and Dr. Seeger, based on their preclinical work, developed a novel method of taking NK cells from a peripheral blood sample from patients and then expanding them in Dr. Dean's lab and all in a central lab by exposing them to a feeder cell line that expresses IL-21 and another co-stimulating molecule to increase both numbers and activation. And the data that Kate has presented to you previously on the NANT 2011-04 trial, we know from that that lenalidomide was able to increase NK cell numbers in the bloodstream in patients treated with that. Next slide. So that as a backdrop led us to open the NANT 2013-01 trial, where patients have a peripheral blood sample drawn and shipped to Nationwide in Ohio. That from that sample, NK cells are expanded over a 2-week period. And during that time, we obtain all the cells we're going to use for all the courses possible on this protocol. And then the patient receives dinutuximab therapy in standard doses. And the NK cells are shipped for the first cycle fresh to the treating site. And cells that are not needed for course 1 are then frozen and will be thawed sequentially for subsequent cycles. And the last dose level after the NK cell numbers are increased and shown to be tolerable, we will add lenalidomide, again, because of the data that it will also activate and increase numbers of NK cells. Next slide. So this trial is actually the first multi-site pediatric phase 1 trial of activated NK cells, and we are currently accruing patients at dose level 3. So this trial has been the first to demonstrate the safety and feasibility of centrally producing NK cells and being able to ship them across the United States and infuse them. Again, at dose level 4, after we complete level 3, we will add lenalidomide. And we're doing a number of correlative studies to look at how long these NK cells will survive in the patient and if they're activated or not, because this is a big issue on these studies, whether these cells will persist. Our second immunotherapy approach trial is NANT 2017-01, again, building on prior MIBG experience and our prior experience with dinutuximab. So we know dinutuximab improved event-free survival for newly diagnosed patients in a randomized national trial from COG, and also had a remarkable 53% response rate when given with chemotherapy for relapsed patients. And there is data to suggest that radiation may actually enhance immunotherapy by changing some of the cells in the tumor microenvironment that promote tumor growth, and by enhancing immune recognition and the infiltration of immune cells, and by generating a systemic inflammatory response. We know that MIBG is one of the most active agents for neuroblastoma, so using that for the radiation portion with dinutuximab, also an active agent, we will see what our response rate is. Next slide. And this is the schema. The MIBG is given on the first day in escalating doses, and we are currently up to 18 millicuries per kilo, which is the standard dose of MIBG. And then on days 8 through 11, patients receive standard doses of dinutuximab with GM-CSF. Stem cells are infused, and that's for supportive recovery of counts from the MIBG therapy. And then there is a second course of dinutuximab given without a second dose of MIBG, since the effects of the radiation should still be persisting. And we are now amending, after we complete the 18 millicuries per kilo level, based on the results of the randomized 11-to-1 study that Kate presented, where we found that MIBG with vorinostat had the best response rate of the 3 regimens tested. We are now going to add vorinostat into the regimen of MIBG with dinutuximab. Next slide. We'll move on now to targeted therapy protocols. The NANT 1502 trial is a phase 1 study of lorlatinib with or without chemotherapy. This is being chaired by Dr. Yael Mosé at CHOP, and she did the preclinical work that is the basis of this trial. We know that the ALK gene is mutated in about 15% of high-risk neuroblastoma patients when they're newly diagnosed. And crizotinib is a first-generation ALK inhibitor. It's currently being trialed in a phase 3 COG trial for newly diagnosed patients that have ALK mutations. And it's being combined with the standard chemotherapy backbone for newly diagnosed patients. Lorlatinib is a second-generation ALK inhibitor, which is a small molecule inhibitor of ALK and ROS1. It has enhanced bioavailability, is able to cross the blood-brain barrier, since we do know neuroblastoma can have CNS metastases, which are an issue. And it is effective in lab testing against crizotinib-resistant variants of ALK mutations, which is may be one of the reasons that patients have escaped crizotinib therapy. N1502, as I mentioned, is based on preclinical work by Dr. Mose, and I think this trial is a very good illustration of NANT's ability for the rapid translation from bench to bedside. Next slide. And here is the schema of 1502. We are dose escalating lorlatinib in two age cohorts, one basically under 18 years and the other over 18 years. The under 18 years is being dosed on a per meter squared basis, and the over 18 years on a just a standard daily dose. So the drug is given by mouth once daily for 28 days for each 28-day cycle. And first we are determining the recommended phase 2 dose, that's the RP2D of lorlatinib alone. And then we will add in chemotherapy with cyclophosphamide and topotecan and determine the recommended phase 2 dose of the combination. Next slide. So to date, we've entered 37 patients on this trial. For reference, the adult dose of lorlatinib for lung cancer, where it's a very active agent, is 100 milligrams per day, which is equivalent to a per meter squared dose of 60 milligram per meter squared per day. So we have found the recommended phase 2 dose for the older population of 150 milligrams per day, and notice quite an increase over the adult dose. And we are pending enrollment to patients that will combine that with chemotherapy. And for the younger age group, we have escalated the dose up to 115 milligram per meter squared per day, so more than twice what would be the adult equivalent dose for lung cancer as a single agent. And we began enrollment at one dose level lower that was shown to be safe with chemotherapy. And this is because we were trying to provide safety data to utilize this in the upfront COG study, which Dr. Dubois will describe more. The common toxicities we've seen with lorlatinib is in general very well tolerated. We do see weight gain, hyperlipidemia, and these are very manageable, very low level liver function elevations of AST and ALT. And importantly, we do detailed neuropsychological testing on these children, and we've not seen any significant neuropsychological toxicity, since this has been a concern in adults. So overall, we've shown that this drug has been taken from lab to phase 3 trial pretty rapidly. Next slide. So again, just to summarize the results of this trial, the ongoing preclinical data that Dr. Mose was doing during the study found that neuroblastoma actually requires higher levels of lorlatinib to be effective against neuroblastoma cells than lung cancer. And we showed by our real-time pharmacokinetic data to get levels of lorlatinib that we could actually achieve these higher levels, and they were well tolerated. We will not report our full response data until our trials are completed, but we have seen responses across the various dose levels, across different ALK mutations, and even in patients with a history of a prior ALK inhibitor. And interestingly, also, we've been following the circulating tumor DNA in the blood, and when you monitor the ALK mutations in the blood, it does seem to correlate with response. So this may be an important biomarker to be an early predictor of either response or progression in future trials. And as I mentioned, there's a pending amendment to substitute lorlatinib for crizotinib in the ongoing COG trial. Next slide. NANT1901, another targeted therapy, and I think Kate presented very nicely the rationale for using an aurora kinase inhibitor. MYC-N, which we know is an important gene in causing neuroblastoma progression and poor outcome, is very difficult to target directly, but these downstream pathways can be targeted. The NANT 2009-03 alisertib trial, which Kate presented, just demonstrated that we can see responses with aurora kinase inhibition. However, there was hematologic toxicity of alisertib that limited dose intensity, required dose reductions, and potentially could have limited responses. So LY3295668 is a selective aurora A kinase inhibitor, which has less hematologic toxicity, with the main toxicity being mucositis. So we're hopeful that this drug will allow more dose intensity and hopefully improve responses. And this is a unique trial. Lilly is actually conducting this trial. Dr. Dubois is actually the chair of this trial, and the scientific design was done with NANT collaboration, and we're using our infrastructure to open it at NANT sites, but it's another new model of how we can work with industry. Next slide. The schema of this, first we again will just determine the RP2D of the drug alone. which is given as capsules twice daily, and then we will add in cyclophosphamide topotecan, determine the recommended phase 2 dose of that combination, and then there will be a randomized portion of the trial where patients will receive either the single agent or the agent plus chemotherapy. Next slide. One of the really critical things with NANT is our correlative studies are embedded into all of our NANT trials, and we have a greater than 95% compliance, which is something I think that's more easily accomplished in a small consortium with more intensive oversight. We do pharmacokinetics, so drug levels, and pharmacodynamics, looking at biomarkers that we've actually targeted the intended target in all of our trials. We look at studies of immunomodulation, and we have 3 studies, 1 completed and 2 that are ongoing, that use a dinutuximab platform. So we plan to compare these 3 when they're done to look at how these various platforms of dinutuximab modulate the immune system. We also look at a profile of the tumor microenvironment, the cells that support the tumor, and again, the electronic repository we have of our scans, and the NB5 assay, as well as circulating tumor DNA at response time points. So these are more sensitive measures of response that we hope to correlate with our radiographic and bone marrow response. And in summary, our results will propel new also preclinical research, as well as optimize future clinical trial design by the close interaction of lab and clinical investigators. Next slide. The precision trial is our NANT 1501 trial, and in this trial we do gene panel sequencing of either soft tissue, bone, or bone marrow samples from our patients. We are determining the number of patients that have genetic alterations that could be targeted with available agents, and also characterize the tumor microenvironment to look at various targets to develop future trials. The report is shared with the treating oncologist so they can use that in choosing therapy. We do not mandate the therapy on this trial. And we're also looking at bone marrow specimens that have a small amount of tumor to see if we can enrich them so that we can do analysis on the bone marrow, because this would avoid the need for soft tissue or bone biopsy. Importantly, in the first 52 reports of the 60 patients that we're targeting on this study, we have found actionable mutations that have available agents in 83% of patients. ALK, not surprisingly, being the most common in about 1/3. You'll notice that's higher than the rate we quoted at diagnosis. And so we know that ALK is more commonly mutated after therapy. And 10 of 16 bone marrow aspirates with tumor were able to be enriched, and we're currently doing the sequencing. So again, we hope this will make this assay applicable to more patients. And I'm not going to go over these numbers, but just to give you an idea, in our biorepository, you can see the large number of specimens we have on top, and then the bottom shows you the number of patients. So each patient would have serial specimens drawn while they're on studies. And so this is a very rich biorepository for both lab research and looking at biomarkers for our clinical trials. And in summary, to end, since 2000, we've had 1,286 enrollments of 760 individual patients on our therapeutic trials, and we've provided essential data to support the rationale for national COG trials, which Dr. Dubois will now discuss. Thank you.
Thanks so much, Judy. I'm really pleased to be able to speak to this group about how the NANT and the COG work together to try to advance therapies for children with neuroblastoma. Kate, next slide. So we've heard a lot about the NANT, 18 centers exclusively focused on neuroblastoma, and really with a focus on patients with relapsed and refractory disease. The Children's Oncology Group is, of course, not exclusively focused on neuroblastoma. It's our broad network mainly in North America with more than 200 centers, but we do have a focused committee on neuroblastoma that really leads trials for children with frontline or newly diagnosed neuroblastoma, and predominantly for patients with first relapse neuroblastoma. And we talk about these organizations as 2 separate organizations, and they are 2 separate organizations, but we're all the same people, and we're all talking together all the time. So we make sure that we always have joint participation of COG and NANT leadership at our scientific meetings. that we have frequent data sharing to help inform our strategic planning about really a national approach to neuroblastoma. And as I mentioned, our leadership teams really overlap, so I am fortunate to be on the executive committee of both organizations. So this slide is meant to show our paradigm for identifying novel agents that ultimately can find their way to frontline therapy. And I'll just emphasize that the strategic mission is really just that, to try to identify promising agents in the relapse refractory setting that then we can move up front to try to prevent relapse in the first place, since we understand that treating relapsed high-risk neuroblastoma is really an enormous challenge. And if we can prevent relapse by bringing our best agents forward, then we think that we'll really be more successful. So in the NANT, sorry, go back one. In the NANT, we'll focus on second and greater relapse, largely phase 1 clinical trials. In the COG, as I said, we'll predominantly focus on first relapse and obviously frontline. In the first relapse setting, those tend to be largely phase 2 trials in the Children's Oncology group. Because we have a larger number of participating centers, we can have larger trials in the COG. And then ultimately going to frontline therapy that tend to be phase 3 clinical trials, where we can randomize patients to standard of care versus standard of care plus a novel targeted therapy. And we also conduct pilot studies where we have new promising agents, but we need to ensure safety before we move on. So I'll share with you now 3 vignettes of agents that are moving or have moved from the NANT to the COG. So that would include MIBG therapy, which really Kate pioneered in North America and really developed throughout through the NANT and the series of clinical trials run through the NANT that Kate reviewed. Lorlatinib for patients with ALK aberrant high-risk neuroblastoma, and then DFMO for children with first relapse high-risk neuroblastoma. So next slide. So I'm fortunate to play a leading role in the COG frontline high-risk trial ANBL 1531. Our overall goal of this trial is to try to understand if the addition of MIBG therapy, which largely has been used for children with relapse disease, if that improves therapy when added to if that improves outcomes when added to COG standard therapy. So this is a trial that is open now at 141 COG centers, and the MIBG is administered at 22 approved MIBG centers. And that point's fairly remarkable, and I think is a testament to the NANT that really helped to develop all or most of the MIBG centers now in North America. We've enrolled 324 of the 774 patients that will be needed to address the randomized question, and we'll expect that this trial will finish accruing in October of 2023. So I'll just take you through patients enroll, they get a cycle of standard therapy, and during that cycle of standard therapy, we ascertain their MIBG status, and we also ascertain their ALK mutation status. Those patients who have MIBG avid tumors that do not have an ALK mutation move on to the randomized portion of the study, where they either are randomized to get the standard of care in the COG or the standard of care plus a block of MIBG after the 3rd induction cycle, and then they move on to the rest of COG standard of care. So this trial was really informed by prior work in the COG, prior work in the NANT that demonstrated safety and dosing of MIBG therapy in the relapse setting. Next slide. We've already heard from Judy about optimizing ALK inhibition. So a first generation ALK inhibitor called crizotinib has shown activity in the phase 1 setting with 1 complete response out of 11 patients with an ALK mutation. But we've understood for some time now that as in many cases, the first generation inhibitor may not always be the best inhibitor. And so in the laboratory, Yael Mosé has shown that a newer inhibitor called lorlatinib has greater activity both in neuroblastoma cell lines that are resistant to crizotinib, so that's the top panel on the right, the F1174, or in cell lines that have sensitivity to crizotinib, that's the R1275Q mutation. They have improved activity when treated with lorlatinib, which is the red line in these two panels, compared to the crizotinib treated animals, which are the blue triangles. So, and what we've seen already from the NANT trial is that this is an agent that appears to have greater clinical activity and also improved tolerability compared to crizotinib. So on the next slide, I'll take you through our thinking of ALK-aberrant patients in the COG. Just as with MIBG, our goal is to understand if adding an ALK inhibitor to COG standard therapy improves outcomes. And so at the time that ANVL 1531 began, we only had available data with crizotinib. And so patients who were identified to have an ALK mutation were non-randomly assigned to receive crizotinib together with COG standard therapy. Now that we have data available from the NANT showing tolerability and anti-tumor activity of lorlatinib, we're actively working even today to move from crizotinib to lorlatinib, and we expect that that will happen sometime in Q1 of 2021. And then on the next slide, I'll just share a few slides about the first relapse trials that the COG Neuroblastoma Committee has conducted. So this is a schema for ANVL 1221, which was a trial for patients with first relapse neuroblastoma. They were randomized to receive irinotecan and temozolomide, plus either the mTOR inhibitor temsirolimus or the anti-GD2 monoclonal antibody dinutuximab. And on the next slide, we see really dramatic activity of the dinutuximab arm of the trial, what we now call chemoimmunotherapy. So you can see that 29% of the patients on that arm of the study had complete responses and 24% had partial responses. The Kaplan-Meier curve on the lower right shows in blue the chemoimmunotherapy with a very obvious advantage for progression-free survival. So this really established chemoimmunotherapy as a standard for patients with relapsed high-risk neuroblastoma. And now our current generation study on the next slide is building upon that success by adding in a new agent, DFMO, that Judy told us about, or maybe it was Kate. Someone told us about it earlier. I think it was Kate. Told us about it earlier. So now we are actively running this trial led by Meg Macy at Colorado Children's and Kelly Goldsmith at Children's of Atlanta, looking in, again, a relapse setting, which we're in the relapse setting in a randomized manner, which we're able to do in the Children's Oncology group, comparing our standard now, irinotecan, temozolomide, and dinutuximab chemoimmunotherapy, or the addition of DFMO. And on the next slide, the rationale for this is that the NANT has shown that this is an oral agent with a favorable toxicity profile. We know that DFMO blocks an important protein downstream of MYC and MYC-N proteins, but also importantly for this trial, blocks some of the immunosuppressive cells that we know are in neuroblastoma tumors. And finally, the NANT trial has demonstrated that this is an agent that can be combined together with chemotherapy, again, paving the way for this now randomized COG trial. So I think I get to extend thank you on behalf of all three of us. A big thank you to the parents and families who have the courage to participate in our clinical trials. Of course, the NANT sites and staff and the funding organizations. many of whom are, of course, members of CAC2. So thank you.
Thank you so much for those wonderful presentations and for all of the work that you're doing with COG and NANT, both of those. We had a couple of questions, as we wrap up the hour, from Mary Beth Collins, who is an individual member here at CAC2. She was curious about the role of Accutane in treatment of neuroblastoma. If one of you might speak to that.
I'm going to let Judy Villablanca answer that because she ran the first studies with Accutane and then helped direct our randomized trial.
Right.
Thank you.
Yeah, well, I mean, as you know, Accutane was studied in a first-line, frontline trial where patients were randomized to get 6 months of Accutane, 6 courses after myeloablative therapy or not. And then we built on that backbone, adding in the immunotherapy. I think, like any of our agents, I think when you change the backbone of therapy, the question is, if you randomize now, would you still need retinoic acid if you had just immunotherapy? And I don't have an answer to that question because we haven't studied that. I think they're also one of the big issues with our phase 1 trial. This was in earlier days. Retinoic acid is, many of you know well, if your children have taken it, comes in a capsule. And when you open the capsule, it's very slimy and not very palatable. But on the phase 1 trial, we allowed opening the capsule, which loses about 15 to 20% of the drug that's embedded in the capsule itself. So it's certainly possible that we may not, there are kind of some conflicting studies about whether you have to achieve a certain level to get responses. So I think that's another issue that really would take a more focused pharmacokinetic trial to dose with pharmacokinetics to determine that. And I guess lastly is the length of therapy. We actually in our phase 1 pilot went out to a year, and some patients took it for 18 months. The 6-month choice, we chose that length of therapy because we thought that was most feasible for compliance at the time. So I think that Accutane, I guess in the long run, the evidence we have is that it did benefit event-free survival. It's a fairly non-toxic agent. It's an outpatient agent. So, but I could not defend the fact that if you did some of these more focused randomized trials, you really need that to tease out the exact role of retinoic acid. And Kate, I'll let you comment since obviously we did those trials together.
No, I think you summarized it very well. I think our challenge with neuroblastoma as we develop new therapies is that things randomized trials showed may not always hold up with new therapies.
Right.
So I think I know there was a question about transplant, and it's the same issue. If you wanted me to discuss that, there are a few institutions now in the US who feel that in certain situations, consolidation with transplant with myeloablative chemotherapy is not necessary. And the problem is, again, there have been 3 very large randomized trials internationally, one here, one in the UK, and one in Germany, showing unequivocally that consolidation with transplant was superior to consolidation with further chemotherapy or nothing. Those trials were all done in the era before immunotherapy. So the question now is transplant necessary in the era of immunotherapy? Well, I would maintain that it is based on the data we have right now when you take all comers, because Julie Park's trial, randomized trial in the Children's Oncology Group, showed that a tandem transplant was superior to a single transplant, significantly so. And when she looked at only the patients who got immunotherapy post-transplant, the tandem transplant was still significantly superior to patients who got a single transplant, again suggesting that even with immunotherapy, myeloablative chemotherapy was a knockout punch that was needed. Now we're interested in refining that. We certainly see some of the selected results from other institutions where some patients are successfully treated with aggressive chemotherapy and immunotherapy without actually the very high dose therapy we give with transplant. So maybe patients who are in a complete response, including a complete response when you analyze the bone marrow, as we have done in some with RT-PCR, very sensitive measures, or circulating cellular DNA, tumor DNA. Maybe there is a small subgroup of patients and maybe a certain molecular makeup of their tumors who will be cured without transplant, but we don't know yet who that is. And we haven't reached, even with tandem transplant and immunotherapy, we're still a long way from 100% 5-year and 10-year survival. We're more like 50 to 60%. So I think it's, at the current time, I still say that patients should be transplanted unless you have some secret molecular knowledge in a certain patient that it's not necessary.
Yeah, I think a challenge that we really face in neuroblastoma is, thankfully, there are not a lot of children with neuroblastoma in terms of like eligible for clinical trials. So it takes us 4 to 5 years to answer a randomized question, which really is the only way to truly know if something changes outcome. And as we identify more molecular subgroups of neuroblastoma, those numbers may shrink because we may take children with a certain biologic genomic profile onto a certain type of thing. And perhaps we'll become more like leukemia, I think where Kate was kind of describing, where we have biomarkers, right? That at certain branch points, you say if you're in a molecular CR, that you go on to perhaps less aggressive or just different therapy than the rest of the group. But I think those are to be determined. But that will be a challenge.
We could address the issue of upfront immunotherapy, which is another possible question.
Yeah, no, I think that's an important point. I'll just echo what Judy said about the molecular subgroups, and I know that the CAC2 is all about collaboration, and in our field we're going to have to continue to be excellent collaborators as we understand that this is a molecularly heterogeneous tumor, and that we will need to collaborate more and more with international colleagues, that even the Children's Oncology Group with 200 plus institutions will not be able to address some of these very important questions in narrow molecular subsets of the disease. In terms of the issue of upfront chemoimmunotherapy, I mean, we're tremendously excited by the results that we have seen in the relapse setting with chemoimmunotherapy, and I think it is now imperative to try to understand if that benefit in the relapse setting can translate into benefits in the frontline setting. So we've just completed accrual to a pilot study looking at dinutuximab added to induction chemotherapy. And if that looks promising, I think we'd all love to look at that in a randomized manner to understand if bringing anti-GD2 monoclonal antibody up front to induction improves event-free survival, improves cure rates for these kids.
Sure. Well, do we have time for one more question about survivorship, or
sure,
do you have a hard stop? Okay.
Steve is.
I'm sorry?
I said Steve could address that.
Sure.
Okay. What current research is being conducted on survivorship issues, particularly as it relates to the transition between child and adults?
Yeah, I think there's a couple of groups that are working very hard on survivorship issues in neuroblastoma, in particular high-risk neuroblastoma, where the therapies that are given as part of frontline treatment are so intensive and have a tremendous burden of late effects. And so there's the NCI-sponsored childhood cancer survivorship study that looks at 5-year survivors of childhood cancer and evaluates a range of late effects and predictors of late effects so that we can understand which of the treatments that we're giving are potentially most deleterious to our patients from a late effects standpoint. There's also now a dedicated study called the LEARN study, Late Effects After High-Risk Neuroblastoma, that is funded by St. Baldrick's Foundation and led by Lisa Diller at my institution and Tara Henderson at the University of Chicago. And whereas the childhood Cancer Survivorship Study, CCSS, it really spans all or many childhood cancer histologies. The LEARN study is really focused exclusively on high-risk neuroblastoma and will be a treasure trove of knowledge for our field. We do in the ANBL 1531 study also have some intermediate endpoints looking at proxy measures of potential late effects. So we'll learn from our frontline trial as well.
Thank you so much. Would you be able to forward us the information about those trials so maybe we could share those with our members
Absolutely.
if that's something that they could be, participate in?
Oh yes,
We
we would love to have survivors participating in both the CCSS and in the LEARN study. So by all means.
If I might add, I think parents also play a critical role in advocacy for third-party payer insurance, because this is a real issue for our survivors. They have a list of side effects, and it's often very hard for them to get, insurance and to get jobs and things like that. So I think that's a real area we can work together with parents on advocacy to have our legislators recognize that we do have more survivors, which is wonderful, but we have to take care of them.
For sure. Well, thank you all. If there aren't any more questions, I don't see any in the in the question log. I apologize. But I'd like to thank each one of you for sharing all of the progress that you've been making in neuroblastoma, Dr. Mathey, Dr. Villablanca, and Dr. Dubois. Thank you so much. And also to Gavin Lindbergh for helping to organize this. And this webinar will be has been recorded and will be on the website shortly. So thank each one of you.
Thank you, everybody.
Thank you so much.
Bye-bye.
All right, have a great day.
Thank you.